All right, so I think we'll go ahead and get started. Welcome everybody to our webinar, Dementia Screening in Community Health Centers, Meeting UDS Data Requirements and Ensuring Effective Care. It's great to have you all with us this afternoon or morning, wherever you're joining us from. I'm Caitlin Sinovac. I'm our Assistant Director for Medical Respite Care here with the National Healthcare for the Homeless Council. In addition to my work here at the Council, I'm also an occupational therapist by clinical training and have worked in the health center setting as well as with the council. And so I'm quite excited about this topic today. I know we have 90 minutes together, but I could talk quite at length about cognition. So really thrilled that this is a conversation that you all are interested in as well. And I am here today with my colleague, Devorah Keller, and I'll turn it over to you, Devorah, to introduce yourself.
Hi, everyone. So delighted you joined us today. My name is Deborah Keller. I'm the Director of Clinical Services and Program Operations here at the Council. And I am also an internal medicine and addiction medicine doctor who really loves working with older adults and like Caitlin, really feel very passionately about cognition, cognitive screening, and supporting people in their independence in the community. So excited to be here with you today and share this content. I'm going to hand it back to Caitlin to start us off.
Great, thanks so much, Devorah. So as we mentioned, we're here with the National Healthcare for the Homeless Council. Next slide. And so we are an organization working at the nexus of homelessness and healthcare. If you are interested in learning more about who we are and our mission, you can click the link that I put in the chat there. And then this webinar, our disclaimer is that it is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services. However, the contents of this webinar are ours and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. Next slide. So our learning objectives for today is that we're hoping that as you walk away from this webinar, although this is focused somewhat on dementia and dementia screening because that's a new UDS measure, which we're going to get into in a minute, we're hoping that you're going to be able to differentiate between dementia and cognitive impairment, identify screening tools and what those options are for screening within dementia within the health center setting, and then also for you to begin thinking about what this workflow might look like for you to be able to complete screening and follow-up assessments for folks with dementia within your setting. Next slide. So our agenda for today, again, this is a longer webinar just because we thought we might have a lot to talk about. We're going to start with doing an overview of cognition and dementia. We're going to review the available screening tools for dementia, and then go into a little bit of depth of what to do and what to think about after somebody has a positive screen, and especially what that might look like in the population of adults experiencing homelessness and those served within the health center setting, which is going to look a little bit different, right? And then we're going to think about what that means, what our care plans can be, both for individuals with mild cognitive impairment all the way through dementia. Because we have a little bit more time today, we also have a case example and we'll have time for questions and Q&A at the end. So we definitely would encourage you, if you have questions throughout the conversation and presentation, please put those into the chat. We're going to keep track of them and then we'll be able to go back to those at the end of the conversation. Just as a note, this webinar is also being recorded and it will be posted to our website where we post all webinars that are recorded along with the slides. So you will have access to this information. Usually takes us about a week to get everything posted there. So this will be available later on for reference and to share with your colleagues as well. With that, I think we can start diving into our content around understanding cognition and dementia. So although we're here again to talk about dementia because that's part of the UDS measure, we want to really scan out and take a look out at understanding cognition as a whole. So we're going to start by defining cognition so that we're all talking about the same thing in the same way. Cognition is information processing functions carried out by the brain. Cognition includes a whole host of activities that our brain is doing all at the same time. This looks like attention and memory, executive function. This is often the things that we are more familiar with in regards to cognition. But cognition also includes our speech, both our ability to articulate and speak, and also understand verbal and auditory information that's coming to us. calculation ability, so math, in a basic way of saying that, visual perception, and praxis skills, which is sort of knowing where your body is. So cognition really encompasses a whole aspect of the person's being and is a very complicated and complex uh, kind of aspect to understand about the person. But understanding what global cognition is really helpful for us in understanding what it can look like, where folks might experience barriers, and then how we can also support them. Next slide. So to break it down a little bit, we have here is illustrated the flow of cognition, right? And so this is also really helpful for us in understanding how our brains work, how our thinking skills work, but also the different areas of where somebody's cognition might be impacted and why. So at the very bottom, so this is kind of a scale up, we have alertness, right? And alertness is very foundational to our cognitive skills. If you are falling asleep while you're listening to me talk during this webinar today, you are very unlikely to be paying attention, remembering information, and being able to do something with the information I've presented to you today, right? Alertness is basic. We have to be alert. We have to be, awake and engaged to be able to even start to begin to learn and process and understand information. After alertness, then we move to attention. Attention is an underlying skill to all of these other cognitive processes. This is really important to point out because clinically, a lot of times I have a lot of folks who come to me complaining about issues of memory, but really where some of the deficit lies is in attention. And attention can be sort of a warning flag that something is going on, but it's also treated slightly differently than we might treat other aspects of this when we're looking at supporting people with cognitive difficulties. So attention, we have to be engaged, right? We have to be focusing on or aware of what is happening to us. So if you're, during this webinar today, if you're checking emails and if you're texting and you're writing a to-do list and you're thinking about how you need to get an oil change, you're maybe not going to be picking up on the information in a way that then your brain can do something with it, those next steps of information processing and then remembering it later and then being able to do an action upon it. So attention is very underlying to all of these other processes. Following attention, we have information processing. And that's really where your brain, I love the little sort of cogwheels turning, right? Your brain is deciding, what do I need to do with this information that I've just attended to? Do I need to do something about it right now? Do I need to store it for later? How much later? Is this something I need to remember to do in 2 hours? Or is this something that I need to try to recall in 1 month? How am I going to do that? That's all information processing, is figuring out what that information is and what do you need to do with it. And if in the case that that is information that gets stored, that goes into our memory. And memory, again, is the cognitive process that I think most of us are most familiar with. People are able to describe most accurately, right? It's part of sort of our colloquial language. So memory is our ability to recall and retrieve information, right? And that can be short term, that can be long term. There's all sorts of different aspects of memory, remembering to do something later versus remembering something that happened in the past. That memory piece draws on being able to attend to and have processed that information. So any issues in those underlying cognitive skills are going to impact our ability to remember information later or an action later. And then finally, at the top of that, we have executive functioning. And then executive functioning is complex. It's made up of multiple different cognitive functions, such as sequencing, organizing, knowing when to get started, knowing when to discontinue what you're doing, being able to respond to things going differently than you thought that they would, and applying and generalizing other skills. So executive functioning is really complex and relies on those other aspects of cognition to know what to do and how to act and how to respond and be able to process that information. So in individuals who have executive functioning challenges, oftentimes there's another area where they're having cognitive issues, and it can be anywhere or all of those places along that flow of cognition. So I'm not expecting all of you to leave this session today being neuroscientists, right? But I think this is really helpful when Devor is talking later about what do we do with this information on these cognitive screens. Cognitive screening tools, especially some of the longer ones, go into some of these different areas of cognition. And that helps us know, okay, if somebody scores really low in the areas of attention, now I know and maybe have some ideas about what I can do to be able to support this person, be able to live the life that they want to live. Next slide. So we have a basic understanding of what cognitive impairment is, or what cognition is. And so now we're going to talk about cognitive impairment. So Lowercase cognitive impairment, so the C and the I are lower, is the term that we use to describe when cognitive abilities are impaired or a person has trouble with cognitive processes that begin to affect the things that they do in everyday life, right? So we can have impacted cognition, but if it's not affecting our everyday life, then it's not necessarily cognitive impairment, right? If you have a bad night of sleep, you're maybe not functioning at your highest, but it's not a recurring problem. That doesn't mean you have cognitive impairment, right? That's a little bit different, perhaps, than when you are somebody who has your brain is working in a different way, right? So cognitive impairment is when we see that affecting everyday life activities. Cognitive dysfunction is the term that we use to describe functioning that is below what we would expect for normal cognitive levels or a loss of ability in any sort of cognitive functioning. So dysfunction is really when we see it when folks are not at the level that we think they should be at, either based on their developmental level or their age level. Again, it's a global, broad term that is not diagnostic, but it describes what's happening. So somebody with a traumatic brain injury might have cognitive dysfunction because of the area of the brain that was impacted from injury. Brain injury is the diagnostic term. The cognitive dysfunction is describing what has happened as a result of that brain injury. And then again, looping us back into that concept of dementia, we have mild cognitive impairment, which capital MCI, or otherwise known as MCI, is different than the cognitive impairment general term that I just described. When we're using the term MCI, this is a diagnostic term that we're using to describe the stage between what we expect for somebody's cognitive performance to be based on their age versus the more serious decline of dementia. So there's some slightly normal or expected cognitive decline that happens as part of the aging process. Mild cognitive impairment, which we'll define in a minute, is beyond what we would expect for normal aging, but has not progressed into dementia. So again, just differentiating because sometimes it can get confusing when we see these terms, and sometimes even clinical notes are not very clear. Mild cognitive impairment, when we see that, that is a diagnosis that's been given to somebody because they have the markers of mild cognitive impairment and there's concerns of progressing to dementia versus lowercase cognitive impairment, which is what we're seeing as cognitive functioning from somebody, which may be related to a whole host of other clinical issues. Next slide. So there's many, many things that can impact our cognition, right? So we're here today talking about dementia, but we're really going to be talking about cognition in general. There's a lot of things that affect somebody's cognition, and there's a lot of things that affect cognition in folks who are unhoused. So in addition to likelihood of chronic conditions, our population of people who are experiencing homelessness are also at higher rates of experiencing behavioral health diagnoses, maybe active substance use. We know that folks experiencing homelessness have higher rates of acquired and traumatic brain injury than the general population. All of these different things can impact somebody's cognitive functioning. In addition to environmental things. So all the things I just listed are medical conditions that folks experience. Environmental are all of the things that affect our cognition that happen outside of us, right? So if you look at that list on the right, we see a lot of things that probably, again, when we're looking at our unhoused population, most folks that we know and are working with probably could check many of those boxes, if not all of those boxes at any given time. So when somebody is demonstrating challenges with cognition, it's not always medical, right? It could just be that this person has not gotten a good night of sleep in many, many months, right? Because they don't have a safe place to sleep. Somebody might not be getting adequate nutrition and vitamins that are going to help cognitive functioning. Chronic stress, right? So all of those things can play into somebody's cognitive performance and what we might see. We're going to talk about this when we get to screening later, but these are really important considerations because if we resolve the environmental factors, somebody's cognitive performance may perhaps improve. So if we screen for cognition at one point and 6 months later, when the person is housed or they have more medical stability in their conditions, we might see a change. And so we need to be really careful about using a one-time screener as a one and done when we know there's all these other factors that are impacting cognition. And again, we'll get into that. Next slide. So it's important to know, right? Cognition drives, and you can click through a couple times to where here. Cognition really drives everything that we do within our bodies, right? And so when we see impacted cognition, we might also see this happening through somebody's physical function, right? The brain is the director of our bodies, and it's directing our movement and our motor actions. So depending on what cognitive skills are affected for a person, we might see that coming out in their motor performance or their physical performance, their ability to plan for and follow through on a movement. If somebody has a more recent physical change or injury, if they have impacted cognition, they might have decreased awareness or decreased ability to plan and problem solve for that impacted movement. One basic example, right, is if somebody has some memory issues or a memory impairment, and they now have falls precautions or a falls risk using a wheelchair, they may not remember certain things that are new skills, like locking their wheelchair brakes before they stand up, or taking their time, or shifting their feet, right? Those are new things that they're not used to doing, and that can impact physical and motor function. Next slide. Additionally, cognition can impact, and our emotional and behavioral regulation are very much interwoven to each other, right? So some of the areas of the brain that control cognition are also the areas of the brain that regulate our emotions and our behavior. So those two pieces are kind of functioning together. If those are both impacted, we're going to see that impact in both of those areas. Additionally, having cognitive impairment or changes in your cognition can really affect somebody's emotional and behavioral response, right? If you suddenly start having significant memory loss, you're going to start to feel anxious about that. Why can't I remember these things? What's going on? What's wrong, right? I feel really frustrated. You might feel very agitated. Folks really have really strong emotional responses when they know that there's a change in cognition that's happened. Additionally, if emotional regulation is impacted, it's really hard to use cognitive skills, right? If you're very angry or very stressed, it's really hard to remember something. It's really hard to pay attention, right? Maybe you had a conflict with someone right before coming to this webinar. Like you might be thinking over and over in your head about that conflict and what you want to do about it. You're not attending to the information here. That's a very normal part of cognition. So just knowing again that where our emotional regulation is and our, kind of our behavioral health symptoms, that is also going to impact how we function in a cognitive capacity. Next slide. So while we're in the process of giving you a lot of definitions, I'm going to give you a few more. So we're going to talk about activities of daily living and instrumental activities of daily living. And one of the reasons we're including that around cognition is that this is where we start to see cognitive impairment. When it's changing for a person, this can really be a red flag around that something is going on. But it's really just sort of how somebody's cognitive processing is generally affecting them overall. So going back to those definitions of cognitive impairment and cognitive dysfunction, right? It's dysfunction when it's impeding somebody's ability to do the things that they need to do in their everyday life. So activities of daily living defined here are activities oriented toward taking care of one's own body and completed on a routine basis. So ADLs are made up of these sub activities listed here, very familiar to most of us. Many of us do them regularly. Bathing and showering, toileting, toilet hygiene, getting dressed, feeding, eating and swallowing, functional mobility, personal hygiene and grooming, and sexual activity. So these are all of the things that make up ADLs or activities of daily living. Next slide. Then we also have these categories of IADLs, instrumental activities of daily living. These are activities that support daily life within the home and community. And we've included them because it's important to think about them with cognition, because these activities are often more complex and require more skills than doing ADLs, right? When we think about development and the things that we learn how to do on our own, ADLs come first, right? These are skills that we've been doing for a long time. Toileting and toilet training happens really young in development for individuals, whereas you maybe don't learn meal preparation until you're in your teens, right? So we talk a lot about ADLs when we think about dementia, but actually, if we look at IADLs, that is where cognitive impairment and dementia might show up first, right? And we're starting to see some emerging data around this when we're looking at the growth of older adults experiencing homelessness. When somebody starts to have symptoms of dementia that are undetected, they will have challenges potentially with keeping up with their home and home management, financial management, and paying bills, which we know has really huge consequences for housing tenancy. this is the places where some of that might show up. It's also a place where somebody with cognitive impairment might need more support. They may be very well independent in their ADLs, but need a little bit of help with budgeting or getting around in the community or communicating around complex situations. So we want to be thinking about IADLs. Health management is another really big piece of that. We want to be thinking about IADLs and how we can support people when there is cognitive impairment, but also being on the lookout for that, especially if you're working in permanent supportive housing and you see people with some changes around that, that may also be an indicator that we need to start looking at cognition. Next slide. And I think, apologies, Deborah, I really like animation, so there's a few things to click through here. But what does this look like when we're talking about people experiencing homelessness, right? When cognition is impacted, it makes it so much harder for people to navigate and engage in services, right? And so when we think about shelter structures or program structures, people need to be able to follow rules. They need to be able to tolerate and participate in large groups or structured activities, schedules that are not developed by them, but are developed by somebody else. And like, we don't give people a lot of grace in terms of making mistakes, especially if there are things around sobriety or returning on time or taking medications, right? And that often in less low barrier environments can result in a loss of services. What does that look like for folks who are struggling with cognition? Well, people who have any sort of cognitive impairment or impacted cognition may have difficulty with managing time, remembering information, being able to remember rules, being able to remember schedules, being able to remember the name of the person they're supposed to ask for at a certain time, difficulties navigating some of those more challenging environments when it's noisier and busier. There's all of these pieces, right? This is not new to us in working in the world of homeless services, but when we layer on those challenges of cognitive impairment, these become so much harder. And it's one of the contributing factors of why folks with medical conditions that cause cognitive impairment, such as brain injury and other disabilities, are more likely to be sleeping outside than in shelter residences. It is because of these challenges. So looking for cognition and cognitive impairment can be a really helpful way for us to be able to think about how we can engage and improve the safety for individuals. Next slide. When we're looking strictly from the healthcare perspective, right, we also need to be thinking about where cognitive impairment might show up and how that can, again, affect their ability to engage in healthcare, right? So we want to be thinking about new cognitive impairment. There's a lot of things that can cause, as we noted, right, medical conditions that can contribute to cognitive changes. Something simple like an infection can impact our cognition. Larger things such as COVID, hospitalization for an ICU, we might find that that's contributing to somebody's cognitive functioning. Anybody living with a cognitive impairment might have challenges doing the activities they need to do for health management. Things like attending appointments, following medical instructions, right? Just thinking about how many steps are involved with administering insulin and knowing how much insulin to administer if you're doing injectable, right? That is really challenging for somebody who might have some cognitive challenges. Taking medications, reading the bottle, problem solving. It says take one by mouth in the evening. Does evening mean dinner time? Does it mean bedtime? How do I know which one is going to be the better one for me? And completing paperwork is really overwhelming for folks, especially if literacy challenges are also involved. So we really wanted to talk about this conversation today because we know that this is a big factor for the populations that are served by health centers. Not only is this a UDS requirement now, but this is something that we should be thinking about to better serve our population. The data is not really robust around the prevalence of cognitive impairment in unhoused populations. It's not widely been screened. Studies that do exist show up to 25% of the health center or unhoused population may have cognitive impairment. But we can assume that that might likely be higher when we know that folks living with brain injury alone are people experiencing homelessness, 50 to 70% of that population has had a TBI at least once in their lifetime. So we might assume then that cognitive impairment is highly undetected in that conversation. We also know that our population of folks that we serve has less access to healthcare, especially specialized healthcare, such as rehabilitation services. There are folks who maybe were not successful in school because of learning differences, right? And have not had the opportunity to learn different strategies to manage that. And then we know that resources impacts how somebody is able to manage their brain health overall. And then finally, when we're thinking again about dementia and age-related conditions, we know our population of folks who are unhoused are more likely to experience age-related conditions 15 to 20 years earlier than folks who are housed. So when we're thinking about age-related cognitive decline, we don't want to be thinking about that in folks 60 and 70. We need to start thinking about that much younger in their 40s and 50s and monitoring that. All right. So now we're going to dive a little bit into talking about dementia, right? This is in the title of the webinar. We were going to get there, but we wanted to have you all have a global understanding and sense of cognition here. Um, Understanding what we would expect around cognition and normal cognitive changes is a really helpful tool in differentiating from dementia-related impairment and what that looks like. If we can understand what that looks like, that's going to help us develop a more effective plan of care, right? So things that we might expect as part of age-related cognitive changes, and we're using the word changes, not decline, because not all of these things are decline, right? But we might expect that it's relatively typical for somebody to forget things like names or appointments, but it might come to you later, right? In a conversation, you forget the name of the person you meant, and a day later, you're like, oh, that's right, it was Devora, I forgot, and of course I remember 24 hours after I met this person. Occasionally making errors. None of us are perfect. Things like issues with bill payment or things like that. Again, not totally abnormal unless it begins to happen regularly and is impacting daily function. Disinterest in social activities, being upset when routines are disrupted, occasional word finding difficulties, all of those things, again, might be things that we expect and we would not necessarily think are an indicator of dementia. Misplacing items, but being able to find them again is a really good indicator of this is, again, just part of normal age-related cognition. And then occasionally making choices that might not always align with safety or realistic needs, right? This is, again, something that we can see happening without it being necessarily dementia. So next slide. I've talked a lot about what dementia is not. So here we are. We're going to talk about what dementia is. Dementia is defined as a general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life, right? So there's that word again, daily life. And now you're maybe recognizing why we're talking about ADLs and IADLs as part of this conversation, right? That interference in daily life is really key and critical. What's also important to note about dementia, as opposed to other cognitive impairment, is that dementia symptoms are progressive, which means that once they start, they may start out slowly and will gradually get worse over time, leading to full dementia. If somebody has other types of impacted cognition, whether that's from ADHD or brain injury or a medical event, we don't necessarily anticipate that to be progressive. We don't think it will get worse, and in a lot of cases can improve with intervention. Dementia is very different in that we will expect a progression over time. It's not always rapid, but can take several years for that to do that. The term dementia is an umbrella term. So we're going to talk through each of these in a moment, but there are several different types of dementia that somebody may be diagnosed with depending on its etiology and how it's presenting. So we'll go through each of those. Next slide. So mild cognitive impairment, capital M, capital C, capital I, MCI, right? This is the diagnostic term. This is a condition involving problems with memory, language, or other cognitive functions that are noticeable but not severe enough to interfere with somebody's daily life. I wish I would have underlined that. Not severe enough to interfere with daily life, right? That's one of the differentiating factors is that we're seeing it start, but it's not necessarily interfering with those day-to-day activities yet. They do not have significant impairment in their abilities to perform ADLs, and not yet do they meet criteria for dementia. They are, however, at an increased risk of developing Alzheimer's or other dementias, but not everybody who has MCI will progress to dementia. Some may improve and some may remain stable. It's important to note, especially if we're thinking about integrated and holistic care, depression is common in folks with MCI, and if there is depression, those individuals are more likely to having their MCI convert into dementia. So we want to be monitoring and looking out for that progression and managing that as well as a way to prevent or mitigate some of that progression into dementia. Next slide. So Alzheimer's disease is probably the most common form of dementia that most of us knows. There's been a lot of advocacy, research efforts, other types of things that have happened around Alzheimer's disease. There's a lot of national organizations focused on this. Alzheimer's disease is defined as age-related irreversible dementia that develops over several years. It is also the most common cause of dementia in folks over the age of 65, and it is the majority of dementia cases. Alzheimer's is not a normal part of aging. It's slow and it is an ongoing cognitive decline that eventually does affect daily activities, right? So there's your differentiating factor. We're progressing into dementia or Alzheimer's from MCI because it is affecting daily activities. At this point in time, there's no cure, and the definitive diagnosis only can happen after the person's death. Although we can identify it now, that definitively determining that that is what was happening for the person happens post-mortem. Next slide. Again, for your reference, these are the additional types of dementia. We have frontotemporal dementia, which occurs specifically in the frontal and temporal lobes of the brain, and often leads to difficulties with communication, goal setting, social behavior, and personality changes. Just like other types of dementia, there's not a current cure or treatment to be able to slow or stop disease progression. Also important to note that frontotemporal dementia is more typically diagnosed at younger ages between 45 and 65. Vascular dementia is a decline in thinking skills caused by conditions that block or reduce blood flow to various regions of the brain. So this can occur most commonly after somebody has a major stroke, or it might gradually develop after an individual has experienced multiple minor strokes. So really important to be monitoring for this, especially in our folks who have cardiovascular conditions. Also does not currently have any FDA-approved drugs to address specifically vascular dementia. And then we have Lewy body dementia, which are protein deposits in the brain that disrupt cognitive functioning. It's currently believed to also be part of the Parkinson's syndrome spectrum. So this one notably results in cognitive and more motor impairments than the other types of dementia. And people may also notice psychological symptoms and sleep disturbances. Next slide. So mixed dementia is when somebody is diagnosed with two or more types of dementia simultaneously. Often what we see is Alzheimer's disease and vascular dementia. This is somewhat emerging. The exact number of cases is not currently unknown, but when looking at autopsy studies, it's more common than previously to be typically believed. And so sometimes somebody might be diagnosed with one single type of dementia, and then post-mortem, they identify that it was actually mixed dementia. So what is the impact of dementia in general, right? And so just like we talked about at the beginning, our brain is the director of everything, right? So when there are things impacting our brain, we're going to see that impacted in multiple functions in the way that our body performs. So we're going to see emotional changes. Somebody's affect is not going to be in alignment with what their mood might actually be. Someone may be laughing while they are sad, right? Things are not going to align in the way that we might expect in that way. They may feel more stressed around new environments, unfamiliar people, unpredictable routines. And we also need to just like be considerate of the fact that there's going to be some baseline stress around the experience of homelessness in general. Sensory, right? So folks with dementia are going to experience a decreased field of visual attention. They're not necessarily going to be noticing the things happening in the background around them. They may also have decreased insight into interoception, which is our sort of our internal body cues of I'm hot, I'm cold, I'm hungry, I'm tired, right? And so that can be really challenging when we're thinking about behavior and mood management, because we know what happens when folks are tired or hungry, right? We're more irritable, but an individual may not be able to tell you that, or in more progressed cases of dementia, even be able to tell you they need to use the bathroom if they need to do that. They also have difficulty filtering out sensory input, which is why it can be so challenging for folks in more disruptive or loud or busy environments. People also will experience changes to taste, their taste receptors, which can impact their appetite and feeding. Again, individuals with dementia may also experience decreased balance, have an increased risk of falls, and more difficulty swallowing as a result of that, and increases those safety precautions and concerns, but might have trouble remembering what those precautions are. And then finally, the cognitive changes, which we've definitely spoken about. What we most commonly see is challenges with memory, attention, problem solving, and sequencing, some of those more executive functioning tasks. All of these things can impact a person's day-to-day function and their ability to do day-to-day activities and live in the environment that they would like to be in. So with that, I'm going to turn it over to Devora, who's going to talk now about screening.
Thank you so much, Caitlin, for providing this extremely insightful review of cognition, cognitive impairment, and dementia. As Caitlin mentioned, understanding these foundational concepts and things like ADLs, IADLs really will help guide the rationale for and the response to cognition and dementia screening efforts that we're being asked to do with this new UDS reporting measure. So in this second half of the talk, what we'll do is we'll delve into the rationale for engaging in screening in the healthcare for the homeless settings and explore some of the pluses and minuses of integrating different tools for cognitive screening. So there's a bunch of different options that we'll introduce, and we'll talk about why some of them, what the benefits and the pitfalls are of some of the different tools that are available to us. And we'll also share a framework for how to think about and respond to the range of possible positive screening results that your patients may have. And finally, we'll offer some actionable steps on what you can do to clarify diagnoses in the clinic setting, and also approaches you can take to support independence and autonomy for individuals with positive screening results. So Alzheimer's disease and related dementia screening is a new measure that's being added to UDS. And this measure will capture both the number of visits where patients receive Alzheimer's disease and related dementia screenings, as well as the number of patients who receive the screening. So both the number of visits and the total number of patients. As I said, we'll go over a list of the standardized tools that are used for the evaluation of cognition and mental status in older adults that are approved to be captured within this metric criteria. And the rationale given for adding these metrics is that this information will be valuable in understanding the level of need and the resources required to continue to support the growing aging population served by the health center program, and that it will foster the early detection for those individuals who are at risk of dementia. So to start, I want to say that no single test, no screener, not a blood test, not neuroimaging can diagnose dementia. A dementia diagnosis comes from a clinician after taking screening tools, history, labs, imaging, and progression over time into consideration. All of the cognitive screening tools that I will introduce in the next few slides provide a score, but not a clear diagnosis. The scores for many of these tools are stratified into ranges: a normal range, mild cognitive impairment, or dementia, sort of the trajectory that Caitlin introduced to you earlier. Okay. To get a dementia diagnosis, a clinician must first rule out all other conditions, both physical and behavioral health, that could be contributing to the patient's presentation. This workup can include sensory and cognitive assessments like hearing and vision tests, as well as formal neuropsychiatric evaluation. It also involves a review of mental health conditions and prior treatment, physical exam, laboratory and imaging studies, and input from care partners about the length and trajectory of symptoms. On the last slide, we reviewed the justification for adding the dementia screening as a trackable metric, and that was focused most on individuals who ultimately get diagnosed with dementia. But as Caitlin mentioned, from an HCH clinical care perspective, I would like to highlight that having this push to identify and document individuals who might have mild cognitive impairment is an incredibly beneficial outcome from this screening metric as well, and will allow us to identify the percentage of folks who have early MCI within the populations that we serve. So as Caitlin mentioned, the rate that while there's not excellent data, there is preliminary data that indicates that the rate of mild cognitive impairment and dementia are significantly more prevalent in unhoused population. The rate of dementia in the homeless population in some studies is shown to be twice that of housed individuals. And as Caitlin mentioned, there's an estimate of up to 25% of unhoused individuals have mild cognitive impairment that could be detectable on screening tests. As Caitlin also mentioned, in the homeless population, the onset of cognitive changes often occurs at younger ages, associated with well-documented premature aging and the early onset of geriatric conditions in this cohort. So while the UDS metric requirement for dementia screening suggests using 65 and older as the age cutoff, for those of us working with homeless populations and for individuals at risk of homelessness, we recommend starting screening at age 55 if you're able to in your clinics. Earlier screening can help to proactively plan for a larger portion of the individuals we serve and can also play a key role in identifying individuals with mild cognitive impairments who may be at risk of losing their housing in the future due to cognitive challenges. As Caitlin mentioned, there is early evidence that the rising population of older adults, there may be a correlation between older adults experiencing homelessness and the onset of cognitive impairment. And many of those IADL challenges associated with mild cognitive impairment could be contributors to first-time homelessness. And this screening is also an opportunity to help address that trend head on. When you're choosing the right screening tool for your clinic and implementing your screening protocol and follow-up plan, there are some additional considerations for health center populations and HCH clinics to consider. The first one is baseline education and literacy levels, which can impact testing, and asking and documenting asking about education and literacy and documenting this in your notes can be really helpful information to use as collateral alongside any cognitive screening tool that you document. In addition, for individuals with limited English proficiency, several of the recommended tools that we'll go over are available in multiple languages, and other tools can be delivered through interpreters. Adaptations can also be made for those who have visual impairments, as a number of the tools require sort of visually seeing something and drawing or writing as part of the test. Screenings are integrated into a variety of clinic visits. Individuals may be coming, and so screenings may be integrated into visits for people who are coming in for a variety of reasons. They may be coming in with other active medical issues or stressors. Some things that Caitlin mentioned, they maybe have experienced poor sleep, safety concerns, food security issues. And all of these factors can impact performance of the test on any given day. As Caitlin mentioned, we should, a screening test on a single day is a screening test on a single day. And it's really helpful to consider these greater contexts in determining the ideal time to complete a screening test and whether or not it should be repeated at another time. And those can be factored in when you're interpreting the score and deciding when to repeat to look for confounding factors. In the next few slides, we'll be reviewing a list of the UDS approved screening metrics. I want to add a quick note that formal neuropsychiatric testing and evaluation is listed as one of the potential tools to consider. Now, I'm not sure if many of the clinicians on this call have ever struggled for or wished or waited for a neuropsych evaluation. I feel like I may have tried to barter my firstborn child in order to get an appointment for a patient that I really felt like I could use the information. And so just really want to flag that this resource is incredible when it is really needed, but it's often an unrealistic and not useful as a clinic-wide screening resource. So given the new UDS reporting requirement, many clinics will be considering ways to add cognitive screening into their clinical workflows. There are a few things to consider as you choose which screening tool to implement. The first consideration is which discipline or disciplines within the clinical team will be implementing the screening tools. CNAs, nurses, prescribers, behavioral health staff, a wide variety of different uh, team members can implement screening tools. However, some of the screening tools are validated to be used by specific members of the care team, and none of them can only be implemented by prescribers. So is a wide variety of people who can implement screening tools, but really important as you're thinking about workflows to make sure that the tool you want to use is validated by the team member that you'd like to be responsible for implementing the screening. The next thing to consider is whether the tool is appropriate to use in the population that you serve. If you serve a lot of people with English as a second language, are validated translations available of the tool that you are interested in using? Is the tool dependent on collateral information from family or friends? Has it been validated with the specific populations that you serve, like the population of unhoused individuals? Another important consideration is how long does the tool take to complete and how that length of time will fit into your clinic workflow. Some of the tools that we'll just introduce today offer more comprehensive screening that do provide more information, like Caitlin was saying, into different domains of cognition. And that can be really helpful for care planning. But if it takes too much time to realistically implement on a clinic-wide screening basis, the benefits of getting that information may not fit in with the challenges of fitting it into a workflow if the screening tool takes a much longer amount of time. So these are trade-offs and considerations to think about when choosing your screening tool. In addition, some of the tools have an associated cost or recommend or require an annual training to be able to be validated to administer and interpret the tool. It's important to consider how these requirements fit into staff training schedules and into budget considerations. And finally, it's important to think about when during the clinic flow you'd like the screening to happen, and based on when you want it to happen, who might be available to do the screening at that time. It is important to note that no matter which tool you used, a trained provider will need to be the one who actually interprets the score, and a prescriber, like a physician, is the one who would be needed to make any diagnosis. So the so both members of the team, both a screener and a physician or other prescriber, will need to interpret the results. So here is the complete list of tools that meet the UDS screening criteria. And we'll walk through some of these tools a bit more closely. So the first tool is the Blessed Orientation Memory Concentration Test. And this test assesses the domains of memory, orientation, and concentration. And it is very sensitive to identifying the early cognitive changes associated with Alzheimer's disease. However, this tool has not been documented to be used with a PEH population in formal studies, so we don't have good evidence about how well it translates into the HCH population. The Montreal Cognitive Assessment, or the MoCA, is one of the most well-known of the screening tools, and this tool screens for mild cognitive impairment, again, through looking at multiple cognitive domains. While this study has not been validated for the homeless population, it has been used in this population in several studies, so it's been published on. In this tool, you may need to use adjusted cutoff scores to avoid false positives amongst the HCH population. And this is one of the tools that requires a paid training to be able to administer, which limits its applicability in many settings. Another tool that many of you might have heard of is the St. Louis University Mental Status Exam, or the SLUMS. And this tool evaluates cognitive function through multiple domains. However, it's not been validated specifically for people experiencing homelessness or people under the age of 55, which doesn't mean we can't use it. It just means it hasn't been specifically validated for those populations. And it has been used in homeless service settings, but not with any formal studies. This tool has similar domains to the MOCA, but it's free and has a free training with it. So in many settings, people tend to use this tool because of that difference from the MOCA with not having a charge. The mini mental status exam focuses on memory, language, and spatial skills. Um, and, and this tool has not been well validated for non-Alzheimer dementia, and it has not been specifically validated for the population of people experiencing homelessness. Four more studies that have been that are on the list. The short informant questionnaire on cognitive decline in the elderly, or the IQ code. This is a very different screening test. This is an informant-based questionnaire that asks individuals to compare current performance with performance 10 years ago. Sometimes people use this screener together with other cognitive screening tools. While this has been used a lot in the community, it hasn't been documented with the HCH population. And in part, one of the big challenges with this test is that there is a reliance on report by someone else in the individual's life, family members or a support person who's known that person for consistently for more than 10 years. And that often can be a barrier for use in our population. Similarly, the AD8 is an informant-based questionnaire, and it also may be a challenge because of the reliance on caregiver support. The final two, the brief interview of mental status has been validated only with nursing home patients, and the mini cog, which tests multiple domains, including visual spatial skills, executive functioning, and memory, has been validated with homeless adults in the past. So as I mentioned, each of these, as you're thinking about which tools to use, thinking through which population it was validated in, what information it provides, and whether or not it's well fitting to your population can help you pick the tool that that makes the most sense to integrate into your setting. Okay, but now your clinic has implemented your dementia screening protocol, and you're starting to get positive results. So how should you respond to these positive screens? So first, I want to pause and return to the concept that I introduced on my first slide, which is a positive screen does not mean someone has a dementia diagnosis. A dementia diagnosis requires further workup and requires demonstration of change and change over time and impact on someone's ability to live independently and to do ADLs independently. A positive screen also doesn't mean that someone has new impairments. It only means that you're newly aware of impairments that exist. And so, especially when you're implementing a new screening protocol, you are likely going to pick up a lot of people who may have had cognitive impairment for a while, and you're just picking everyone up at once because now you're screening for the first time and you're picking up what has already existed. A positive screen also doesn't mean that someone cannot live independently in the community. And I think if there's one sort of side message in addition to sort of what we can do and how we can advocate with this information, this is the one piece of information that I really want to make sure is a key take home, which is just because someone has a positive screen, and even if someone ends up with a diagnosis of mild cognitive impairment, that does not mean that they can't live independently in the community. It just means that we know more about the changes in their cognition. So what a positive screen should do is provide an opportunity to explore further, to work up the causes and the contributing factors, and to identify ways to support individuals across the spectrum of cognitive changes that were introduced earlier in the talk. So here are some recommended steps to take as part of the initial clinical workup after a positive screen. So the first step is to take a thorough history. In addition to someone's past medical history, you should explore their developmental history, their history of traumatic brain injuries, behavioral health history, including mental health and substance use history and treatment courses. And if community supports are available, families, friends, longitudinal case managers, it can also be really helpful with the patient's permission to ask about noticeable changes in mood, cognition, safety, and self-care, and get a sense of trajectory and change over time. When completing a physical exam, it's helpful to do and document a full neurologic exam if there isn't one already documented at the chart, just to establish a baseline. It's helpful to rule out active infection such as a UTI or pneumonia or cellulitis or other active medical conditions that could be causing a low cognitive, a low score on the day that it's done and could be confounding the test results. And then you should consider whether or not completing or referring for functional assessments are relevant. As Caitlin highlighted, sometimes cognitive impairment could then lead to functional challenges. So really thinking through as you're doing these initial workup, whether or not OT, PT, other functional assessments, hearing, vision would also be things that would help to clarify what's going on and identify reversible causes. Then it's also really important to assess for the whole range of reversible contributors to cognitive impairment that might be at play. Key first step is to complete a medication review, including prescription medications and any over-the-counter medications or supplements to see if there could be confounders and things that are contributing to poor cognition. Running lab studies to assess for reversible medical conditions like thyroid conditions, syphilis, and B12 deficiency that are known to lead to cognitive impairment. And then to screen individuals for sleep disturbances, including obstructive sleep apnea or chronic poor sleep, as was mentioned as a real driver for issues with cognition that could be reversible. Finally, I think it's important to consider the role of neuroimaging with a non-contrast head CT or an MRI. I frequently will, given the prevalence of traumatic brain injuries in the population, I frequently check the chart to see if imaging has ever been done in the recent past or the remote past, and leave this step as a to be determined depending on how the rest of the workup plays out. Now that we can interpret positive screens, I want to take a moment to review a key concept that Caitlin had introduced at the start of our talk, which is the difference between the changes seen with normal aging, mild cognitive impairment, and dementia. And I'm a visual person, so I wanted a chart that helped me look at it. And the chart on the right offers a simplified version of these changes over time. The mild changes in cognition that can be seen as part of the aging process are sort of that green line, and the mild cognitive impairment, which is the subtle decline in cognition that can be age-related, or in the HCH population may have earlier onset as a result of traumatic brain injury, prolonged exposure to substances like alcohol or methamphetamine, for the subset of individuals in the community who have substance use disorder, the sequela of longstanding serious mental illness for the subset of individuals who have SMI, nutritional deficits, or sequela of untreated medical conditions. So in the population of people experiencing homelessness, mild cognitive impairment, which is often seen, at a later age, could begin somewhere along the spectrum at earlier ages as well. In the setting of mild cognitive impairment, the cognitive changes, which may be detectable on the screening tools that your clinic implements, do not significantly interfere with daily activities. And they also, as Caitlin said when she was introducing these concepts to us, may not progress over time. So some of the individuals who are being screened for the very first time may have been functioning, who have positive screens for the first time, may have been functioning successfully in the community with this level of cognitive impairment for many years before they were diagnosed for the first time, or these issues were identified for the first time on a screener. So as I said before, this screening doesn't mean that the impairment is new, just that we're newly documenting it. In contrast, dementia, which is a clinical diagnosis made with clinical data, um, represents a cognitive decline that progresses over months or years and becomes severe enough to get in the way of social activities, occupational functioning, and daily activities. And so it's when that diagnosis happens once someone passes that line of being able to take care of their daily activities. I do anticipate that the majority of the positive screens in the HCH setting will identify individuals within the mild cognitive impairment range through the range of individuals with early dementia. And so sorting through two key questions, has there been concerning progression over time? And has the level of cognitive impairment impacted your patient's ability to safely and independently function in the community? Have they tipped over that dotted line on the graph between independent functioning and the need for a lot of assistance? These are the key questions that HCH clinicians should ask after they receive a positive screen. And these questions can help the clinic determine which level of support an individual needs and how to triage additional diagnostic resources and community supports. So here are a list of recommended healthcare considerations that can apply for individuals who screen positive on one of the screening tools and may have symptoms ranging from mild cognitive impairment through early dementia. Once someone screens positive, all of these items should be on your radar for regular consideration when someone comes into clinic to see you for follow-up. For me, the first stop is always around medication safety. So review of medication lists, simplifying dosing schedules, and deprescribing when appropriate, especially if there are medications that are known to cause confusion or are flagged to be less safe for older adults on that are on patients' medications lists. Taking care of that and reviewing that first is the first intervention that can really make a difference for folks. The second stop for me is considering the care management and self-management tasks that individuals need to do to care for their health. This care management and self-management was on the list of IADLs that Caitlin introduced to us, and it is a sphere that could be one of the earlier areas where people start to struggle and need extra help. So asking about difficulties, simplifying tasks, and considering whether someone needs some extra support to be able to take care of complex health care management needs is a really helpful first step in responding to a positive screen. And I do want to point out that the council has a comprehensive care management toolkit that's available that we can drop the link to in case you would like to explore the topic of care management and how to support individuals further. Now, HCH care always centers around partnerships, and this is even more important for individuals with positive cognitive screens. Community partners can play important roles in identifying support needs and filling gaps. For example, medication reminders, community navigation, and assistance with bills and benefits. Many of these supports may already be in place before you have your positive screening results, or it can be resources you consider exploring and layering on after a patient screens positive and after further exploration identifies they would benefit from additional support. And in all of these areas, if you're using one of the screening tools that allows you to see which domains someone lost points in, can also help identify where someone could benefit from help the most. Is it problems with memory? Is it problems with organization, executive functioning skills? And that could help guide you towards which resources and which supports in the community could help them the most. Now, I always appreciate the opportunity to plug the importance of advanced care planning within the HCH population, and do consider this an essential conversation for everyone we work with across the lifespan. However, these conversations rise on my list of priorities when there's a concern for cognitive impairment, with the goal of exploring healthcare values, wishes, and most importantly, the identification of a surrogate decision maker before cognition declines further, and it's difficult to have these conversations with patients. And similarly, the council has a training course that we developed with the Housing and the Homelessness and Housing Resource Center that focuses on advanced care planning, and we can drop a link to that as well if that would be helpful for folks. In primary care, we have the privilege of supporting individuals over time. And so that provides the opportunity to monitor for that change in cognition, the change in ADL and IDAL capacity over time, and then guide us for the need for additional workup and services. Now, when it does feel like things are progressing, that's the time when I reach out for that elusive neuropsychiatric assessment to help me figure out if, to help me further ascertain what's going on. So when there's community safety concerns, when when there's clear documentation of progressive deficits, or when I need help, or when you can use help advocating for services or specific housing placements, those are times when formal neuropsychiatric testing can be really helpful in elucidating some of those details and for advocating for necessary resources. So as I started to say on the last slide, screening results can inform housing advocacy and support. Individuals with cognitive impairment and even mild dementia can live safely in the community, either independently or with some community supports in place. At the same time, this screening can provide information that you can use to advocate for the most appropriate housing setting and the appropriate supports that can help maximize independence for individuals for the longest amount of time possible. So clinicians can pair screening results with more robust functional assessments like OT and PT evaluations to identify additional areas in need of support and put those in place. Positive screens can also prompt clinicians to develop and work with patients and their community supports to develop individualized safety plans. And finally, for individuals who are housed, a positive screen can help identify those who may be at risk of losing their housing due to early manifestations of cognitive impairment that we've mentioned already. And these can really allow clinicians to put supports in place to address these challenges before the individual risks homelessness, either for the first time or for individuals in supportive housing for repeat homelessness. If someone does have a diagnosis of dementia, this and sort of meets all of, after fuller evaluation, it's helpful then to begin planning for a potential need for transition to higher levels of care and to really focus on safety planning in the community. So our last slide before our case study is really trying to highlight some reasons why you might want to refer someone to specialized care. It is because access to specialists are often limited. It may not be realistic or appropriate to refer everyone with a positive screen to a neurologist or to otherwise specialist provider. So here are a list of key triggers that might warrant specialist referrals. Someone who's having worsening behavioral or psychological symptoms, delusions, hallucinations, anxiety or depression. When these symptoms and behaviors are impacting quality of life, they may require some specialized interventions. When someone is an increased fall risk and that is overlapping with their cognitive safety planning, and any reason why cognitive decline is affecting safety in the community. Someone who is having uncontrolled sleep disturbances with a lot of shift between day-night sundowning, or a shift between day-night confusion, and then progressive dependency in ADLs for someone who does have someone like an in-home health aide, caregiver burnout, and a transition to resistance in receiving community supports that are in place. These are all reasons why you might consider referring someone to specialized care and for further assessment. I know that was a lot of information. I think we were hoping to, that was like an hour and 10 minutes of information. So thanks for bearing with us. We thought we would try to make it real with a case. So I'm going to pass it off to Caitlin to walk us through.
Perfect. Thank you so much, Stuart. Yes, hopefully this will be kind of a chance to be thinking about how you would navigate this within your own clinical or work setting and what this might look like for you. So we have a sample MoCA, the Montreal Cognitive Assessment Tool, that was, a sample done by an individual. And so taking a look here, I know that it's probably a little small, so I'll kind of walk through it, but this is a nice visual of what the MoCA tool looks like. And as Devorah mentioned, the slums is very similar, structured very similarly, but you can see here in this MoCA that there's the different domains. So there's visual, spatial, and executive functioning assessed at the top, followed by naming, memory, attention, language, abstraction, delayed recall, and orientation, right? And the score is based on how many of those questions the person either correctly answers or does not correctly answer. So we have a few questions here when we're looking at this individual's MoCA. So in case you can't see, at the very bottom, this individual's total score was 21 out of 30. Some other pertinent information. This is a 59-year-old individual who was 59 at the age of assessment. They also have a documented clinical history of anxiety, depression, and PTSD. They're currently managing the anxiety. When screened, they also screened positive for a history of head trauma, which resulted in a coma for 2 weeks. However, this information was not documented in the person's medical chart and only elicited when that screening occurred. So that's sort of our clinical history information that we have about this individual. Just a few reminders around some caveats around this. The typical cutoff score for normal, I'm going to put that in quotes, but that's based on the language of the MoCA, normal cognitive impairment is 26 or higher for the MoCA. However, when we look at additional studies that have looked at using the MoCA in a variety of populations, they recommend altering that cutoff score to 23 to adjust for different education and literacy levels experienced by different populations. So with that information in mind, this individual still falls below either of those cutoffs, whichever one you may decide to use within your clinic setting. So what are the things that we would want to think about when we consider interpreting this person's MoCA score, right? So I'm going to harken back to Devorah's statement that a positive screen is not equivalent to dementia diagnosis. So feel free to throw into the chat kind of what are your thoughts? What else would you think about for this individual based on that history that you have and that you know, and based on the score here? What would we want to think about in terms of what we would do with this information? And we can kind of answer questions 1 and 3 at the same time. How might you follow up clinically then, considering those different factors? And I'll throw you the easy not answer. The not answer is to say this person has dementia, right? So how are we going to think about this differently? How are we going to use this scoring and information? You can also feel free to raise your hand and we can call on you and you can come off mute if typing is not your jam. Anything specifically that we would want to look more into or that we think might be affecting some of these domains of cognition? Okay, so great, like looking at medication, right? Even doing a chart review. What medications is this person on? What are they currently taking, right? Because we know what is prescribed versus what is being taken can be different. Have we done some medication reconciliation? Yeah, that's a great place to start, right? and something that we might do as part of our routine clinical practice anyways, especially if you're a prescribing provider, right? So not necessarily an extra step, but something that we want to make sure that we're checking in on. Anything else we might want to investigate further with this individual? And how would you use this information ongoing, right? So again, it's hard to see, so I won't ask this question particularly, but some of the areas where this individual scored lower were in the domains of attention and language, as well as delayed recall, right? And so that's always really interesting to me because those are so interconnected, right? If we see challenges with attention, those challenges with memory make a lot of sense to me. And then similarly with language, thinking about that information processing or self-expression, what's that coming across? Yeah, somebody also answered in the chat, maybe considering educational records, right? That's not information I provided you. Maybe we don't have that information. How would that inform that? I've noticed a lot of times those language questions are especially hard for folks who have less education, and sometimes, again, can contribute to a potential false positive because that's a skill that is more known with higher education. And when you look at who this measure was initially validated on, it was folks who are college or higher educated. And so that can be a discrepancy that we might see. Yeah. So as an OT, my initial steps are going to look a little bit different than Devorah's, but perhaps we can both share a little bit about what we might do if this was our person sitting in front of us. So as an OT, I don't diagnose. I just write up a lot of things that I see based on my evaluations and recommendations for providers. So depending on, why this person was referred to me, certainly referring back to that initial provider around these results, right? And from my perspective, we're really looking at functioning. So this score, I'm going to combine with what is the person telling me about what their function is? Are they bothered by any of these things? Do these issues show up for them in everyday life? Do they have trouble communicating with other people? What are the circumstances where that's happening? I have folks who have a lot more challenging times communicating when they're within the shelter setting or like a busy clinic setting, but do fine in one-to-one individual, right? Being able to differentiate that of where the environment is playing in. And also, is the person bothered by memory? Have they figured out workarounds, right? That's a really big key indicator is that, you see a lot of people who are concerned about their memory, but they figured out what to do about it. They've got some tools and strategies. Is it showing up in their lives? Oh, I really can't remember to get my bill paid on time. This is becoming a big problem. I've missed a whole bunch of my appointments, right? Being able to strategize around what those challenges are is another indicator of the person needing help or just kind of digging into what's going on further with that individual. And then again, sort of from the OT clinical perspective, the goal is to work on that, provide those recommendations that inform the care plan. My goal is to help people live the lives they want to live and also get them to be able to stay engaged with our services, right? If somebody has challenging memory issues, that's a person that is maybe not showing up to our clinic or our healthcare space at all. Or they're the person showing up every morning because they can't remember when they're supposed to come in and it's causing a problem, right? So how can we make sure that we're working with that person, getting their needs met in the way that they need to and benefiting from the services we have to offer? But I'm going to throw it to Devorah from a physician's perspective of what you might think about and do next.
Just figuring out how to find my box. I I prefer to lead with what the OT would do. Usually it's much more relevant to someone's actual life. But I think in this case, I would start with a bunch of the things I had on my chart, like really doing trying to do that robust med review of understanding what the individuals prescribed versus actually taking. I would probably want to get labs to rule out reversible causes. And with this history of head trauma, really with a prolonged coma, which is this is someone who I might consider doing head if we don't have brain imaging available to us, we might consider brain imaging as part of the workup for him.
And someone also messaged too, thinking about vision, right? So seeing that visual perceptual piece, right? Sometimes the low-hanging fruit is vision and hearing. Hearing issues can look a lot like attentional issues. And actually, if somebody is able to hear what you're saying, a whole lot of things can open up for them. Getting your hearing treated, especially if there is hearing loss, has actually been demonstrated to delay onset of cognitive decline, because that's a world of sensory information that we're getting. So hearing and vision adjustments are a huge thing that a lot of our folks lack and don't have access to, and sometimes might be a really good way of one, addressing what looks like cognitive impairment, but also potentially being a prevention strategy as well. So we have 9 minutes left, and a lot of information. Um, there was one question, Devorah, in the chat, if there were any common drugs or medications that cause cognitive problems in the elderly that you can think of offhand.
I'll go pull a list of like a website that you can look up older adults meds. There's something called the Beers criteria that you that sort of highlights, but it's hard to go through. Like, I mean, there's certain meds like benzodiazepines and Benadryl and things like that. But I'm happy to drop a resource where you can sort of search medications.
And the other question that we have for you all, this is just the beginning, right? So this is a somewhat new UDS requirement. And so we wanted to get this webinar launched for you all to give some initial thoughts and guidance around how to integrate this within your settings. But we will be continuing to put out additional guidance through publication and another virtual conversation that we're going to have later this year. And so we would love to hear from you all about what might be useful to have in terms of a publication or other follow-up conversations. What's going to be most beneficial in supporting you in implementing these screenings in an effective way across your healthcare settings. So would love for you all you can again raise your hand or throw that in the chat. I am also going to launch a poll just about today's session and hoping that you all will answer those questions simultaneously. I talked about not multitasking earlier, but I just asked you to do it. But we'll launch a poll about today's session. And then please also, for us, feel free to share in the chat anything that would be really helpful in the future around this topic in terms of guidance or support. I'll just note, Devorah just shared in the chat the criteria she was talking about for medications and older adults. And then
I'll go
again,
back to share. I'll go
oh,
back
go
to
ahead.
sharing my screen. I wasn't sure how to look something up and share my screen at the same time.
And then again, this recording will be posted. I put the link in for our website where we do post all of our recorded webinars. So you can look for that posting there or share with colleagues that might be helpful. This webinar along with the slides will be posted to this page. And then I think without any additional questions or thoughts, Devorah and I are happy to hang out for an additional minute or two to answer any questions. But if not, we want to thank you for joining our webinar today and being interested in this critical topic, not just in screening, but really making screening work for you and the folks that you will be screening. And we'll again be on the lookout for a publication and another opportunity for conversation on dementia screening in the future.
Thank you so much for joining us today.